Hello, I'm Dr. Cam Kalontarzadeh, and today I'm going to be discussing closing the gap. How can we drive down health disparities in anemia of CKD? These are my disclosures. The aim of this presentation is to bring greater awareness of and discuss strategies to achieve health equity in patients with anemia of CKD to help close the disparities gap. Anemia of CKD is a public health problem in the United States and one that varies in prevalence across gender, age, race, and ethnicity and socioeconomic status. Anemia is common in patients with CKD and is often undertreated. The definition of anemia of CKD can vary depending on which guideline we look at. According to KDIGO, as shown here, anemia of CKD in adults and children aged greater than 15 years is diagnosed when hemoglobin concentration is less than 13 grams per deciliter in males and less than 12 grams per deciliter in females. It's our understanding that according to estimates in 2017, nearly 40 million Americans have CKD and about 6 million have anemia of CKD. However, less than 34% of patients report being treated for anemia. Notably, prevalence in the US also varies by demographic, with the prevalence of anemia of CKD stages 3 to 5 in US Medicare patients being higher in women compared with men, and higher in Black patients compared with white patients. Anemia can contribute to the impairment of health-related quality of life and physical functioning in patients with CKD. It typically presents as tiredness, fatigue, and low energy, among other unpleasant symptoms that you can see here on the slide. In fact, tiredness or fatigue is the most frequently reported symptom, and 70% of patients report that it impacts their day-to-day lives. 91% of clinicians report fatigue as the symptom with the greatest impact on their patients' ability to carry out daily activities. And 39% of patients report not working due to their condition. So it's clear that a considerable number of patients with anemia of CKD report reduced health-related quality of life. Health disparities exist in anemia of CKD, where certain populations and subpopulations are disproportionately affected by the disease. The World Health Organization defines health disparities as systematic differences in health status of different population groups. The lower a person's socioeconomic position, the higher their risk of poor health. And these disparities have significant social and economic costs to both persons and societies. In the US, Black Americans, Hispanics, and Native Americans are disproportionately affected by CKD. Differences in treatment practices have been reported among racial and ethnic minorities compared with Caucasians. And these differences are compounded by other social factors such as poor literacy and financial challenges. And by poor literacy, we mean the degree to which persons or organizations have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. As mentioned previously, CKD is highly prevalent in adults in the US. However, Black Americans, also known as African Americans, and other racial and ethnic minority groups are at increased risk of the chronic kidney disease. Compared with Caucasians, African Americans show a higher prevalence across advancing stages of CKD progression and a higher prevalence of anemia. Risk factors such as diabetes and hypertension, which are widespread in the African American community, appear to be the reason for this decline in renal function in this group of persons. As you can see, multiple factors contribute to health disparities in anemia of CKD. Firstly, limited healthcare access is an issue for minority groups. Minority groups who are medically disadvantaged groups are more likely to live in poorly resourced communities and may be less likely to receive timely dialysis in the form of peritoneal dialysis or hemodialysis, or less likely to undergo kidney transplantation. In addition, access to treatment options such as hospital-based hemodialysis may be limited for patients from rural communities. High health care costs mean minority or disadvantaged groups are more likely to be unable to afford recommended care, which results in delays in obtaining treatment and poor treatment adherence. Patients with lower health literacy encounter greater difficulties in understanding written and oral health communications or navigating healthcare environments. And lower health literacy is associated with lower likelihood of kidney transplantation referrals among patients who are receiving hemodialysis treatment. In Hispanic participants, not speaking English at home increased the risk of not receiving recommended health care. Underrepresentation of minorities in clinical trials is an additional problem. Of the 32,000 individuals who participated in new US drug trials in 2020, only 8% were Black, 6% Asians, 11% Hispanics, and 30% were age 65 or older. Fear of mistreatment and exploitation among minority groups can also lower willingness of potential participants. And finally, racial bias in healthcare algorithms, also known as structural racism, can contribute to these disparities. The nephrology and kidney care community has an opportunity to address some of these factors and try to close the health disparities gap in anemia of CKD. As previously mentioned, patients with anemia of CKD have substantially poorer health-related quality of life outcomes compared with patients with CKD without anemia, as evidenced by lower assessment scores. The data shown on this slide is from the Adelphi Real-World Disease-Specific Program for CKD, which is a large real-world cross-sectional multi-country survey of physicians and their patients. More than 5,000 patients with a mean hemoglobin level of 11.5 grams per deciliter completed 3 patient-reported outcome surveys to assess health-related quality of life. The Euro-QOL 5-dimension 3-level or EQ 5D3L, the Kidney Disease Quality of Life or KDQL 36 instrument, and the Work Productivity and Activity Impairment Questionnaire, as you see here. Results of these surveys show that CKD itself markedly reduced health-related quality of life, and this reduction was exacerbated by anemia. Interestingly, evidence shows that correction of hemoglobin levels in patients with anemia of CKD is associated with improved health-related quality of life scores related to tiredness and fatigue. What can we as healthcare professionals do to incorporate health equity in anemia of CKD care? The first strategy could be to ensure effective communication, because lack of communication is a key risk factor for poor health outcomes. Methods to improve communication between healthcare providers and patients can include a renewed emphasis on healthcare provider training on effective communication, easily readable, jargon-free educational materials for health risk communities. Guide healthcare providers on the appropriate use of health back or teach to goal method, whereby patients explain what has been told to them. This can improve communication between patients and healthcare providers and help improve patients' knowledge and self-management of anemia of CKD. Provide cultural, socioeconomic, and gender diversity sensitivity training to healthcare providers to ensure an awareness of patient diversity. Collect data on patients' primary language to inform the provision of potential translation services for healthcare providers and patients. An awareness of patients' primary language can also ensure that education is culturally and language appropriate. Develop programs led by community health workers to train healthcare providers on effective communication with diverse patient groups. In a pilot study, members of the Latinx community indicated that low health literacy and lack of language interpretation were among the most distressing aspects of living with kidney disease. Support by community health workers in language interpretation, clinical trial visits, patient activations, and decision-making helped improve patient-centered outcomes. Another strategy could be to address health literacy and language barriers by first evaluating health literacy using assessments developed to accommodate each community's language and culture. Secondly, developing technology-based community strategies, for instance, interactive multimedia programs that are tailored to reach community. Thirdly, kidney advocacy and outreach may be improved if healthcare providers engage with patients using social media. And finally, establishing navigation programs where healthcare providers from within the community collaborates with community health workers to address health literacy and language barriers. Increasing diversity in clinical trials would be another important strategy to achieve health equity in patients with anemia of CKD. Diversity could be increased by building trust, ensuring participation is advertised and offered across diverse communities, engaging communities as partners before trial commencement to better understand their needs and ensure that research protocols align with those needs, building community engagement into budgets, maintaining partnership with communities after trial completions. And community health workers can also build trust by serving as a bridge to healthcare. Improving accessibility. Minimizing geographic barriers by implementing decentralized methods of participation and data collection, and ensuring greater diversity in the cultural trial workforce. Implementing digital health technology. The FDA recommends digital health technology as a key strategy to enhance diversity in clinical trials. Examples of digital health technology include electronic sensors that detect and measure physical or chemical characteristics and transmit information to study database, for instance. Equitable use and digital literacy of digital health technology must be prioritized for all participant groups. Finally, I would like to summarize this talk on health disparities in anemia of CKD and how we can close the disparities gap. Firstly, we discuss how anemia is common in patients with CKD, with a higher prevalence found in women and Black patients with CKD stages 3 to 5 associated anemia, as compared with men and Caucasian patients, respectively. We discussed how health disparities arising from low health literacy, financial challenges associated with recommended care, and poor community resourcing result in minority groups being disproportionately affected by CKD. We also touched upon the correction of anemia and how it is associated with improved health-related quality of life assessment scores in patients with anemia of CKD. And finally, we discussed strategies to improve health equity in patients with anemia of CKD, such as ensuring effective communications, improving health literacy, and increasing diversity in clinical trials. Thank you.